it was very, very difficult to, you think of PA school as drinking from a fire hydrant. It was crazier in a subspecialty, multiple subspecialties as a general cardiology PA. And I think as long as I stayed humble.
Hi, everybody. Hello, happy Monday. Welcome to eShadowing. As you all know, I'm Rodalyn, and today we have PA Viet here tonight with us. Thank you so much, Viet, for coming on tonight.
Of course.
Thank you. I know that there was some issues with registration. That's why there's not that many people here tonight. But I hope that I'm sure more people will start coming in. But yeah, I hope you guys didn't have too much trouble trying to get into the webinar. But yeah, so we'll just jump right into the session, guys. Thank you for coming and happy Monday. So as I said, we have PA Viet here. He is a cardiology PA. He's not only a cardiology PA, but he is also an associate professor at Rocky Mountain University and the president of Association of PAs in Cardiology. So, and I thought that was amazing to have him here. And today's going to be all about cardiology, and you guys are going to learn a ton of great information that'll help you in PA school. So thank you so much for coming on.
Yeah, of course. Hello, everyone.
Alrighty, guys. So we're gonna first start off by learning more about Viet's journey to PA. So can you tell us why you decided to become a PA and how you even learned about the PA profession?
Yeah, no, I mean, it's been interesting. My undergraduate was exercise science, and I was actually, for a short period of time, a certified athletic trainer. So if you don't know what an ATC is, the person that runs out on the field when you see one of your favorite athletes go down. That's what I did. And I taught at a local high school here in Utah, and just realized after 80 plus hours a week of covering games, etc., practices for all high school sports, I probably need, it was a little untenable for family life. And I reached back to one of my mentors who happened to be the head athletic trainer for the basketball team at the University of Utah. And he had gone on to PA school. So he said, Viet, you'd be wonderful as a PA. You should leverage your training from athletic training over to PA school. And so I thought actually I'd be an orthopedic physician assistant, but I applied, got into PA school, and boy, I tell you, I was not expecting to be accepted so soon. I mean, I got an invitation for an interview and thought, well, wait, I was not really ready for this. Um, so I ended up working through PA school, which I don't really recommend, but I leveraged my exercise science degree for cardiac therapy and worked at the local, at the time, it was the flagship hospital for Intermountain for cardiovascular care. And so on the weekends, I did Saturday and Sunday, I worked as a cardiac therapist. And then the rest of the time I was in PA school, through didactics and clinical practice. So when you ask me about cardiology, it was kind of a natural thing to, because all of the cardiologists at the area and the nursing staff, et cetera, they all knew me as the therapist on the weekend. And I was invited to do a rotation and ultimately was hired out of PA school into the practice. Yep.
Wow, that's awesome because, a lot of new grads have to wait months to get that first job. And, it's a lot of times it's not the ideal specialty or job that they want. They just kind of have to go and get that experience. So
Exactly.
you ended up falling in love with cardiology through working in cardiology while in PA school.
No, absolutely, absolutely. And while you're in school, that second year is a clinical time frame. It's our clinical rotation, similar to a third, fourth year med school clerkship. And I chose to do my rotations at the local VA, at the George Wallen, used to be Salt Lake VA Medical Center. In 6 months of internal medicine, I can only tell you that in internal medicine, I actually participated in their cardiac risk reduction clinic. I was doing some of their surgeries while I was supposed to be clinical, just outpatient. And that really solidified my love for cardiology.
Wow, nice. nice. So, so you ended up doing a cardiology rotation in PA school. How was PA school otherwise? And especially having to work during the weekends, how did you make time to juggle that? And like, were you just like studying throughout the whole weekday, or did you like, how did you balance that?
And I don't know that I did it very well to begin with. Ultimately, I did keep my GPA 3.7 and above. I think at one point I had a 3.9, but just for those that are not familiar with that first year, the didactic year is just crazy. But remember, I took this in 2002. I entered PA school in 2002. And since then, I think they added a full semester. So it's 27 months, whereas for me, it was 24 months. But I actually worked on the weekends as a cardiac therapist. And then during the week, if you know 24-hour fitness, I don't know if it's around anymore, but I was actually a personal trainer, and I would get there. Yeah. So I would get to 24-hour fitness because it's 24 hours open. I got there at 3 a.m. and trained until 5. And then I would do my homework there from 5 to 8 to get to the program, start my classes and go from 8 to 5. And then I went back to do training from 6 to 9 in the evening. That was the first 2 semesters. And it wrecked me.
How did you sleep?
I didn't, not very well anyways, not very well. But I learned the 3rd semester, I just did cardiac rehab, and it was nicer. In fact, it felt like, wow, I lost like this part-time job that was killing me and was able to focus a lot more on my studies. I am fortunate that the clinical rotation at the VA really brought back everything that I kind of jumbled together during that 1st and 2nd semester. It all kind of became a lot clearer as I was practicing at the VA.
Oh, that's awesome. That's great. At least, if you were to have a job in PA school, it's related to, medicine and healthcare. So
yeah.
I'm still learning.
Well, in many ways, my personal training, I was able to leverage what I do now in cardiology. I do a lot of lifestyle recommendations. And so, my exercise science background and then the actual practical usage as a personal trainer of helping people through diets and exercise and physical activity, just that motivation actually of walking people through their training has been very useful as a cardiac PA, as a cardiology PA.
Right. Awesome. So, I'm guessing that the hours you had as a athletic trainer helped you get into PA school. Like they counted as patient care hours.
Absolutely. Yeah. In fact, I would definitely count athletic training as patient care hours. Yeah. I did a lot of patient care hours, both in a PT clinic as well as on site, doing therapy for my students when they were injured. Yeah.
Okay. So, what was your least favorite class in PA school versus your favorite? And the rotations. What was your least favorite rotation?
Oh man, you're gonna call me on this. I will tell you that for rotations, there was not any rotation that I did not enjoy. I stayed away from OB-GYN. But it was necessary, and I should have paid more attention in it. But as a male, it's really tough. We weren't allowed really into a lot of rooms, and I was okay with that. I didn't take offense. I recognized that. Remember, if anything, you get anything out of this, for those that are listening, look, we're given a lot of license as clinicians. Patients have to be vulnerable. I have to be vulnerable when I'm a patient and I put on a dressing gown. It's an uncomfortable situation. You have to be very vulnerable. And so I recognize that. And as a student going into an OB-GYN rotation as a male, I did not take offense when women did not want me in that room. It was okay. So I don't know that it was my favorite rotation, but I didn't get as much out of it as potentially I received out of every other rotation. The classes, I would say I did not like infectious diseases. ID is tough. It's
Yeah.
a very tough thing. And even now, I have to rely fairly heavily on UpToDate and my infectious disease colleagues. Whenever I run into some problems, I always call a friend. It's nice to have partners that know this stuff. So, yeah.
Awesome. So, how was that learning curve? Because you were able to get a job right outside of school, but then working as an actual provider, graduating straight out of school. Even though it was in cardiology and you had some experience in cardiology throughout PA school, how was it just being a PA and a provider and getting that level of autonomy?
Oh, I will tell you, we were in a unique situation. And it was, I don't want to say Wild West. I think that, okay, so first of all, in cardiology, you have to recognize that there's several subspecialties in cardiology. Cardiology by itself it just isn't one thing. There's heart failure, there are electrophysiology, so pacemakers, etc. You have non-invasive cardiac imaging, so cardiac MRI, SPECT, PET, echo, interventional cardiology, where folks are putting in stents, and then it's not just heart stents, but they're putting in carotid stents and lower extremity femoral stents. So it's peripheral arterial disease intervention, and then structural heart, where you're now, in this age, we live in a cool age where we can put stents inside valves, and you don't have to crack someone's chest open to replace an aortic valve. So there's all these subspecialties. Well, back in 2004, several of these subspecialties hadn't actually had their own boards. They hadn't had their own training. It was Wild West. And, interventional cardiology was like, well, I want to start doing stents in the carotid. So they started doing it. Well, I covered, along with there were three PAs. One left a month after I got there. But Steve Mason and I, we covered 13 physicians, and they were of themselves of different subspecialties. So we two PAs didn't practice general cardiology. We practiced EP, heart failure, interventional cardiology, non-invasive imaging. We didn't board through any of that. We just ended up supporting all 13 physicians. And I'll tell you, the funniest story was when I admitted a patient from the emergency department for arrhythmia. They had an atrial fibrillation. And I was suspicious that there was possibly some coronary issues going on. So I talked to my EP attending, who said, well, let's talk to the interventional guys. I said, well, are you going to call him? No, you go talk to him. So I talked to his partner, my physician partner, and told him what I was thinking and what I thought we should do. And he says, great, you can write up the note. So I wrote the consult for EP and for interventional, and basically talked to myself through these two notes and admitted the patient under all of that. It was pretty wild. But I would say that it was very, very difficult to, you think of PA school as drinking from a fire hydrant. It was crazier in a multiple subspecialties as a general cardiology PA. And I think as long as I stayed humble and willing to say, I don't know, please teach me that, my partners loved that, because then they understood like where my gaps were, and they were able to sit down and teach me. So I learned a lot about echo reading. I learned about nuclear imaging, and I was on the floors admitting patients, and I understood at a high level what my fellows, the physician fellows, were doing in cardiology, because that's how they were teaching me as well, and having me work with the fellows very closely. So it was tough. It was tough back in those days. And currently in research, I cover all those subspecialties again. But after 17 years of practice, it's a little bit easier.
That's insane. One question I have, and I'm guessing, I'm just like blown away, is how did you get used to all those personalities? Like the doctors, especially the way they practice, and like having varying opinions and views. Like one may say, oh, I believe in this research, that I mean in the ER they even like ER docs and the hospitalists, they butt heads. So that how did you like get used to 13 physicians, like super physicians and varying subspecialties?
No, it is. I mean, you bring up a great question. It's a great point, and I think hopefully I can come back to just being humble and recognizing that you don't know everything. So actually, that first 2 years that I practiced in cardiology, I left for a time, but that practice, what it taught me was if someone had a strong opinion, then obviously I wasn't going to change their minds very readily. But if I didn't know the treatment and I didn't know the data myself, then I had to just do whatever they said. What I ended up doing was, as I was learning through these subspecialties, I went and looked at the evidence-based medicine. I looked up the current research in any of those practices and the clinical trials that we had at the time. So if I didn't agree with what they said, I would generally say, hey, what did you think about this and this trial and the recent evidence that shows that this is the guideline and this is the way you would go about it? It put my suggestion at a very high bar that they would either have to argue with their own studies or say, well, it is because I just want it to be that way. No one wants to look that way when in my note, I say, this is the suggested guidelines, but we went this way. And I would make them sign it.
Right.
After a few times like that, many of my partners at the time realized, oh, Viet is actually reading through these studies and is actually putting out therapies that are evidence-based. So that's really how I approached it. I didn't ever butt heads with folks. I just told them the evidence as I knew it.
Right.
And always use the most current guidelines. I still do the same thing now. And it puts a high bar out there for people to argue or say no against.
Awesome. That's awesome. Thank you for that. Yes, I use UpToDate all the time. Thank you. So I have a few questions already coming in from students. Let me see. Okay, this is really good. How do you help start and build on conversations with patients to improve their lifestyle and heart health?
Yeah. No, that's a great question. And first of all, you start with not being judgmental, because all of us, look, I've been a cardiology PA, I've been an athletic trainer, I love to go running, hiking, etc. But I also know that my BMI is 30. I may not look obese, but I don't know, maybe I do look obese, but that's at the obese level. I have a BMI of 30. And I recognize that I fall off the wagon in terms of exercise and eating right, etc. I have my own primary care provider. So I reach out to them with the idea of lifestyle as a way to improve quality of life. The benefits of that lifestyle are just really just gravy. Forgive the use of gravy, but it's just extra. It's extra in terms of what it does for your cardiovascular health. But when I talk about foods, I talk about them in the way of making you feel better, and that the engine runs better when it's given better fuel, and that when you run it through its paces, it feels better. If it happens to improve your cardiovascular health, great. Because I know of multiple marathon runners and cyclists that have suffered heart attacks. They eat right, they do everything, but they survived their heart attack because their threshold for health was so high surrounding that heart in that heart event. So that's the sell for me. Is I say, look, wherever you're at, any activity is actually better than none. And the recent physical activity guidelines from 2019 show that data. I mean, just going from sedentary to 5 minutes of walking a day, you could see the impact on events. It dropped dramatically. Now, optimally, it's 150 minutes a week. And we talk about that. I'm like, what's optimal? What's in the guidelines versus what we see as beneficial to begin with. So I tell people, start low, go slow, meaning titrate slowly through it, but go. I mean, that's the message, is you start low, go slow, but go. And then if it happens to build and build and build, great. Because I think they feel better as they're out and active, and they know I'm not going to judge them. I tell them I'm going to follow up to see how well they're doing because I want them to feel better. But it's never about me, the big stick of physical activity on their head or diet. No one responds to negative feedback very well.
Right. Great advice. Okay, another question says, I have heard that a cardiologist, MD, is one of the busiest doctors because of emergency calls that can happen even on your off hours. What is it like for cardiology PA? I guess also like work-life balance as well.
Yeah, I would say that it's a funny thing. I think people get into their heads that PAs somehow work less. But to be honest, if we're working in true team-based practice, we take call and we take just as many hours of treatment or therapy or whatever of practice as our cardiology physician partners. It really depends on where you're at. I had a slide. And let me just take a peek here. Yeah, so really practice, this question is important because I think it depends on whether you work in a health system that is well developed. Like Intermountain Healthcare, we're a very well developed system, and in the hospital I work at, we're tertiary care. So we get all the referrals that the community hospitals can't take care of. We're the next level in terms of care. So that means that our hours are a little bit higher in terms of what we see. The severity of disease is higher. We see a lot of complicated cases. Now, if you're in a rural or a community hospital, that may be less. That may be more if you're the only person covering. So it really depends. If you're just doing outpatient clinic, because there are just outpatient cardiologists that don't cover inpatient, it depends if you're affiliated or if you're employed by that hospital system. So there's a lot of really it depends. And as I said, subspecialty work, you've got EP, you got interventional cardiology, you have all this other stuff going on. So it will depend on all of that. But I think, honestly, PAs do have the opportunity to really define better their work because, we're not quite the physician in that conversation who does have to cover, depending on your state law in supervision. But, as cardiology PAs, I think it would be inaccurate of me to say that we're not as busy as our cardiology physician partners. But we certainly have the opportunity to work less hours.
Okay, I'm going to answer a few more questions, and we're going to move on to Viet's presentation, guys. So one question I had was, how did you all adjust to COVID and when it hit versus now? I know, the heart doesn't stop beating. People need that heart health. So what did you guys do at your practice?
So I will tell you, as you look at the data, it's interesting. We were kind of knocked back a good 20, 30 years in terms of cardiovascular care. And let me explain that. When folks had a heart attack in the late 70s and early 80s even, at best, all you had was morphine. Maybe you could give them aspirin. You give them oxygen and hope they survive through the night in order for you to do something different. They didn't do bypass emergently at that time. So if you survived, then they would say, okay, let's have you rest for 6 weeks, bed rest, and then do a bypass. Well, as you move forward, we had clot busters, then we had balloon angiography, then we had stents, and now we have this 90-minute door to balloon time. So as soon as we find you out there in the field and you're having a heart attack, we bring you in, and then as soon as we can, we get you to the cath lab and open up that blood flow. But in the time of COVID, people got scared. They were more scared of coming to the emergency department. They were more scared of coming into clinic when they had pain. So they left disease to, time is tissue. So more death of tissue occurred. We're seeing really stuff that I used to think was old school stuff, Dressler syndrome, all this other stuff, that rupture of left ventricle, etc. That you only heard of in the books, but now we're seeing it again because people waited too long. Yeah. So from a standpoint of cardiology, we were fortunate at Intermountain Healthcare. We didn't have a lot of furloughs. In fact, we had no furlough. Intermountain stayed really loyal to the community by staying open, recognizing that at some point we would get through to the other side of this, and we switched to telehealth visits. We switched to really restrictive, highly protocolized, visits in the clinic. People were waiting in the parking lot, and we would page them to come in and be registered and then go to clinic. So we did, some funny things. But from my perspective, the thing that really changed healthcare was COVID in the sense of access, because when you have 90% plus people with smartphone devices, we can do tele-video visits. You can do it in the comfort of your own home. I like to see how people live. because it helps me to understand their physical activity. It helps me to understand the true medicines because they can pull them out of their medicine cabinet rather than, I think I'm on some stuff. We can look at those bottles. And I can look at someone and say, geez, you don't look so healthy. Maybe you should come into the ED, and so when you have stable visits, it really helps to get people still engaged, keeping track of their health. Um, it's been interesting. Hope it's been interesting, but I hope that we've learned one thing, which is improving access to care through technology.
Nice. Yeah, that's been great. That's been great. Okay, another question from a student. One more question, then I'm going to move on to the case study, and we'll answer more questions once we finish the case studies, guys. Okay, how to answer this one already? The answer is okay. If you are involved in cardiac research, do you know about comparative effectiveness research? How often do you balance government involvement in healthcare while looking at the pros and cons of health interventions in the cardiovascular field?
That's interesting. I don't know that I know what you mean by comparative effectiveness research. With regards to what we do in our current clinical trials, we look at randomized clinical trials. Typically, I mean, this is your tried and true randomized clinical trial. You look at an intervention versus a placebo or some other comparator. So a lot of what we do is still under that type of research where you basically take a disease, you want to look at this therapy, and then you have to compare it against the placebo or some other standard care. And what you want to know is whether or not those that received the treatment had better outcomes than those that either received placebo or the comparator standardized or standard care. So that's typically what we do. More and more, we're doing what's called pragmatic research, which is really, a randomized clinical trial is very, very rigid. It's very rigid in terms of its inclusion. And so we think of these as inclusion-exclusion criteria. Inclusion would be, do you have the disease? Are you of the age that commonly occurs with this disease? And then do you have these other parameters that better define what this disease is? It's very tight, though. The exclusions then are like, boy, if you happen to have this other disease, we're gonna roll you out. If you're of a certain age, you get rolled out, etc. And so that way it tightens things, because observational trials tend to be like, you come as you are, and everything can confound the findings of your study. So as you do a randomized clinical trial, it's very tight, and then they're fairly long. Most of these are at least 5 years. You want to look at outcomes over a 5-year period of time, especially if you're thinking, man, long-term outcomes, whether this affects people and continues to affect them in a good way. So that, pragmatic trials then are just basically, well, we have actually look up the adaptable trial and the current preventable trial. Adaptable really just looked at the dose of 81 milligrams versus 325. Funny enough, we really don't have good evidence on which is better. It's a funny thing. Most of the guidelines suggest 81 milligrams, but they're like, well, okay, 325 is okay. So we did a pragmatic trial on this, and wouldn't you know it, but it turns out either one's okay. So I usually just use 81 milligrams because there's less bleeding with using a lower dose if it's as effective. So I don't know about the comparative effective research. That maybe it depends. Maybe that's for a specific type of disease or behavioral. I'm not sure. Maybe you can clarify a little bit for us what that means. But balancing government involvement, we don't do a lot of that either within our area of research. If you're thinking of like maybe the recent COVID vaccine trials and whether or not this Operation Warp Speed, how that affected vaccine trials. Honestly, I find that NIH funded trials are nice because if it's not funded, you can't do the trial. So if you don't have federal funding or some other large donor, then you're left with pharmaceutical trials, which, yeah, you have to remember that they're in it for a profit. It's not always altruistic, but without those trials, you never push forward treatment. So
Right.
it's kind of a tough thing. And I think pharma gets a little bit of a bad rap. I think like any of us, they're just, they're trying to make money, but they're trying to also improve people's lives and healthcare through, some type of study drug that they're hoping to put out there.
Right, right. Thank you for that. Okay, guys, we'll answer some more questions later. We're going to move on to have the case study presentation. Viet, do you want to, you can either share your screen or upload it under, if you should see on the right hand side, it says like slides, like little panel on the right, or you can share your screen. Share your screen is at the top, where the little monitor icon.
Yeah, let me see if I can get this to share correctly here. So I'll share. Okay, so hopefully you're seeing the screen with the gentleman in the bottom right corner.
Yes.
Okay, so, I'm in a general cardiology clinic, but I started a lipid clinic 2 years ago with my partner, Dr. Jeff Anderson. And partly because of this type of patient, which, when you think of cardiovascular events, we think of maybe, 60-year-old male and a 70-year-old female. But here we have a 42-year-old male with no history of diabetes mellitus. That's what DM means. He doesn't smoke, and his blood pressure is 120/80. So right off the top, you're like, oh, this guy's young. He didn't have any diabetes. He's not smoking. His blood pressure looks fine. So already you might just dismiss this person a little bit. But his father suffered a heart attack at the age of 45. And then you perk up. You think, wow, at age 45, well, this guy's 42. So it prompted today's consult. Then, you're like, well, okay, blood pressure's fine. He doesn't smoke. He doesn't have any diabetes, but let's do some blood work here because we want to assess his personal cardiovascular risk profile. Typically, that means looking at lipids, your cholesterol. Comprehensive metabolic panel includes glucose. It looks at kidney function. It looks at the electrolytes and, liver function. Well, in the form of transaminases anyways. And that's because if you do start some therapies, you may impact those. You want to get a baseline. And a complete blood count may also help if they happen to be, severely anemic and or they have polycythemia where the hemoglobin hematocrit is really high. Maybe there's something else that might be driving his risk. Additional labs for my lipid clinic, I look at it, looks like A1, but it's A1C. That's that 3-month average for glucose. And then HSCRP, which is specific to the heart. It's an inflammatory marker. And then lipoprotein A, or often called LP(a), is an atherogenic molecule. It's very similar in appearance to LDL cholesterol, but it happens to be a better predictor of risk than LDL cholesterol. So we do that. And this is kind of what we see. Total cholesterol of 300, which, by the way, anything over 200, you're like, whoa, what's going on? It's 300. Well, an LDL cholesterol of 205. And so to kind of put that in context, when you're in neonatal development, at most you're at 30 milligrams per deciliter for your LDL cholesterol. In the American diet here, we happen to be kind of in the 120s, 130s. Here's a gentleman in his 205. Okay, so it's definitely high. HDL is 60, triglycerides 150. His comprehensive and his CBC are normal. A1C doesn't look diabetic. HSCRP is, it's not really, inflamed. 2 or greater, it makes you kind of wonder. But an LP(a) should be less than 30. And when someone's at 50 or higher, you start to think, elevated risk. Here it's 60. So he's kind of got 2 strikes, well, 3 strikes really. His dad had a heart attack at age 45. His LDL cholesterol is 205. His LP(a) is 60. And so you look at him and you think, well, he doesn't look like he would have heart disease. So you think, well, what's driving this LDL cholesterol? And furthermore, why are family members having events early? So in this case, we think of familial hypercholesterolemia. Now, there's heterozygous, which means you inherited one of the mutations from a parent. Homozygous would be 2 mutations, one from each parent that happen to have the mutation. And so typically, we look at these large tendon xanthomas, or you may have seen this. And if you've seen this in someone or yourself, where they have plaques around the eyes, up along the eyelids, etc., these are xantholasmas. And then this arcus senilis. We typically say senilis because we think it's in older adults, but corneal arcus, where it's white rimmed along that cornea, is suspicious for deposits of cholesterol. So when you see these, you're like, whoa, I better get a lipid test. In this case, heterozygous don't often present with these stigmata, with these physical signs, unless they happen to be in the 300 range. Let me put this in context. So here's a male population, age 50. 94% you wouldn't expect a heart attack. Maybe 6% would have a heart attack at age 50 in the general population. Well, in a familial hypercholesterolemia population, 50% as opposed to 6%. 50% of them untreated may have a heart attack. For women at the age of 60, maybe 5% in the general population have an event. When they have untreated familial hypercholesterolemia, about 30%, 1 in 3. 1 in 2 males, 1 in 3 females. So this gentleman that came to us has a potential 50% chance of having a heart attack by the age of 50. So when we come back to him, here's everything kind of put back together. There's 4 known genetic mutations, and so I would send him for a genetic consultation for having a gene testing. And one of these 4 genes here, ApoB, LDLR, LDL-RAP1, or PCSK9, will probably get a hit in terms of pathogenic mutation. Now, if he doesn't have a pathogenic mutation, it doesn't actually mean he doesn't have familial hypercholesterolemia. It just means that in this day and age, we really haven't defined all mutations that are consistent with FH. He has the clinical picture. What he doesn't have is one of the known mutations for pathogenic familial hypercholesterolemia. So again, 50% chance that each child may inherit. I would say the most important thing is it wouldn't stop me from treating him, whether it was positive or not, in terms of his mutations. But if I found a genetic mutation, it would allow me to identify one of his children. If he had 4 children, 2 of them most likely have the mutation, and we can treat them early. The earlier you can treat these individuals, the longer you can stave off having a heart attack, and you may even normalize it so they never have a heart attack. So that's really the case study here. I'm sorry, I forgot if the format was that I should really have involvement.
Oh, no problem. No, it's great. No, it's fine. That was great. Thank you so much for that. That was awesome. Do you guys have any questions about that case study? That was a very informative case study. Thank you so much. You guys have any questions about the case study? That was very interesting. So when they find out about like the familiar hypercholesterolemia, I'm sure they're being that it's they know that they see that this is what you have, this is genetic. That are they more willing to like go about like changing like their lifestyle habits and exercise, eat right? And because a lot of times my patients say when I tell them you have high blood pressure, they don't take it serious because they can't feel it. They can't see it. It's not until that they have a stroke or they have a heart attack that when it's affecting them and when it's like physical that they start to take it serious. So when you kind of show them this picture and show them that that this is a genetic disorder, like how do they respond to that?
No, it's a great question. I would say again, it kind of depends on how they came about being seen by me in clinic. This person is obviously motivated because of his father's heart attack at his age to come in. And so generally speaking, they already have the motivation. They're in that stages of change. It's easier to move them along and say, okay, I mean, you have your dad. If he's had an event at 45, you're 42. And now we know that you have at least, you know, your LDL cholesterol is 205, you have LP little a, so certainly you have risk. If they have a positive genetic mutation, then it is much easier to say, well, you know, let's start this, let's do this. And a lot of times they get on it, but guess who falls off the wagon? All of us. So I just support them. I say, look, this is a lifelong journey, and I want to keep that life long. So let's continue to work together. If you fall off the wagon, just know that this is a journey. No one becomes perfect after one day of exercise. It's not like you're gonna say, whoa, I love this so much, I'm gonna do it for the rest. No, I mean, we have bad days. And so I tell them, look, I'm here. Let's just do this. Start something. You'll stop a few days or drop off a few. Don't worry about it. And by the way, report that to me. Don't feel embarrassed. It's something that I'm here to work with you. So I think it's a great question. And I think one of the things that we use in my clinic is coronary calcium. We do a lot of coronary calcium studying, because if the presence, just so that, you know, those of you that don't know, coronary calcium is a fairly late finding of atherosclerosis. It means something about the way that you, either inflammation or something else, has taken soft plaque and calcified it. And so when we see calcification, we know there's this process of inflammation that's occurred. Most all of us have some type of soft plaque. So there are people with calcium 0, but have soft plaque inside. It's those that have soft plaque that calcify that are at higher risk. And when I show that to them, when I show them a picture of their own arteries being calcified, that means something different than if I'm like, well, theoretically, you have this risk of 2% per year, and in 10 years, you might have a risk of 12% of having an event. They're like, I can't wrap my head around those risks. But when you show them coronary atherosclerosis, they're like, wow, I've already developed that. You know, wow, I have this genetic mutation. So yeah, I should work with it. So I would say we have a 95% plus success rate of keeping people on meds and helping them work through that healthy lifestyle process. But you know, there are those that are like, you know what, it is what it is. I'm just gonna roll the dice and go with it.
So a good question is, when you say you'll be able to treat his children, what would that look like?
Oh, good question. Yeah, there's actually there's a great paper from, and maybe I can drop it in here. I can see that I can type a comment. So let me see if I can lure your ink. Oops. It's a 20-year follow-up, and it's in the New England Journal of Medicine. I used it. There's a great table in there that shows the children of patients that have familial hypercholesterolemia. And actually, they compare the siblings, the non-affected siblings that didn't have the mutation versus those that had the mutations. And when you say treatment, it's statins. You start statin treatment at your early age. I work with a pediatric cardiologist up at the University of Utah. He gives me the parents. I send him the children. And so we do reverse cascade screening all the time. He'll find the children and then test the parents and go, whoa, they have it too. So they come to my adult cardiology. I send the pediatrics to him, and he will start statins as early as 10 years of age because of this paper and others that have shown that earlier you can normalize that LDL cholesterol level earlier, then you lower the burden on the coronary arteries, and they are less likely to have events. And in fact, this paper showed, 0 deaths in a 20-year follow-up. Some had events of heart attack and stroke, etc. But man, compared to their parents, which was like 20% of the parents had an event, but only like 1 or 2% of the children had events.
Wow.
Yeah. So it's one thing to find disease, it's another to tell people we can impact the outcome of disease.
Yes. Wow. That's amazing. But you don't do anything else. You don't do like aspirin or anything. Just statins alone have been shown to be effective.
Yeah. So statin, certainly you don't use aspirin until after the age of 18 because of Wye syndrome. But yeah, I mean, and just to be clear, when we think of aspirin, just recently you probably heard in the news, oh, no aspirin for primary prevention. That's not necessarily true. You should only use aspirin when someone has evidence of atherosclerosis. Okay. So in primary prevention, those are people that we do a coronary calcium scan, we see atherosclerosis. because it's that process. You don't prevent a heart attack with aspirin. What you do is, well, yeah, I guess you can prevent a heart attack when you clot. You know, if atherosclerosis breaks off and it starts to plug up, what aspirin does is it reduces the amount of fibrin and platelets in that area so blood can go through. But why would you give someone aspirin if they don't have any atherosclerosis? And that's been the problem is when we willy-nilly give people that are high risk, but they don't have atherosclerosis, well, why? It's not beneficial.
Thank you. Thank you for that. Awesome. So somebody said, wow, this is incredible. The same way.
Okay.
All right. Let's see. Do you often work with genetic counselors?
Yeah. Oh my gosh. No Lipid Clinic would be complete without genetic counselors. And by the way, if that's a way you want to go, please, I need more genetic counselors to work with. It's tough. It's really tough. There's a lot of information that you need to be able to take in as a genetic counselor. And I don't think they get enough credit. I give my genetic counseling colleagues credit because they are just so important in discussing and helping patients to understand that why cascade screening is important, that inheritance. I mean, I know it now because I've worked with them enough, and we trade kind of secrets, not secrets, but we do our own rounds once a month, and we discuss cases, and it's amazing. We couldn't do it without genetic counselors.
Great. Okay. Someone had a question about switching specialties. Are you aware of how difficult it is to switch specialties? So you were out of cardiology for like 2 years?
Oh, 8 years. Yeah.
Oh, wow. What made you do the switch, and what was it? What did you go into?
Yeah. So, like I said, I was hired right out of PA school into cardiology. And from 2004 to 2006, I did cardiology with this 13, physician practice. I left because of the same problem that I ran into with athletic training as, with supporting 13 physicians. They have their own specialties. I covered all of their specialties. So basically I did the work of 13 physicians. And they forget that. Because each of them are like, oh, the PA will do it. The PA will do it. Well, each of them were saying the PA would do it. And it got to a point where, by that point I had my second child, and we couldn't do it. I got into it because I love medicine, but I also got into it because I love my family, and I wanted to support them and have a good profession that would support my family. But it was not, unfortunately, we could not come to a compromise in terms of time. And then ironically, that's the same group that hired me back in 2012, because I kept, when I left, I did not burn any bridges. They knew it was a family issue. It had nothing to do with the practice, had nothing to do with my love or hate of cardiology. I loved cardiology. All of them knew that. And I made sure not to burn any bridges. But I left to go to occupational medicine, which really was kind of a medical, legal, disability evaluation and occupational medicine. I didn't treat patients for 8 years. I did evaluations for disability for the VA, for the state of Utah, and for the federal government. So they would send me disability cases, and I would help decide whether or not one event led to a disease. And it was really interesting and a lot of fun. I would have kept doing it, except we lost our contract at the VA. I was a contractor. And so then I thought, well, gosh, I'll just go back to what I used to love, cardiology. And reached out to my former director at that time. He was the director of our clinic, and he said, yeah, come on back, but please come into research instead. So I started my research career.
Wow. Okay, so it was no clinical work for 8 years.
Yeah, no. I saw patients, but I did not treat patients.
Right.
Yep. So I did all the usual physical exams. But I reviewed some of my most difficult patients. I was reviewing nearly 4,000 pages of medical records, and some of them dating back to 1940 to World War II.
What? Wow.
Yep.
Wow, that seems time consuming. So how was it going back to like the kind of the more like clinical side of things? Was it like muscle memory as far? But I mean, you were still able to retain it because you were reading so much about like their medical records and everything. So
No, no, it's a good question, and boy, I felt a little nervous. I felt a little nervous coming back into clinical practice. There was, it's a little bit like riding a bike, but in the 8 years that I was gone, there was so many new medications
yeah,
that were available, and I was like, oh my gosh, it's a smorgasbord. There's so many new things that I get to learn and do, and so it was fun. It was a lot of fun, but boy, I was nervous. I was really nervous. I thought, well, you know what? Because the therapies were different. The way that we came about it was different, but the disease process was the same. And really, I just had to level up on the newest guidelines. And by the way, that was the easiest way to do it, was go back to the guidelines and say, well, what's the rationale here? What's the background? What changed? And so I would plead with you, if you're ever out there, just go with the guidelines first and then work backwards into more specific stuff.
wow, thank you for that. Okay, so we have time for like one or two more questions, guys. Can you briefly discuss a day in the life as a cardiology PA? What duties do you take in comparison to your MD partners? I'm sure it's a lot of duties, as with the 13 different MDs. So,
well, it's very different. I mean, in the life of me as a cardiology research PA, I will tell you that they've given me a lot of latitude. I built this position. I was the second PA that they had hired as research, but the first PA quit within a month of me being hired, and I've been it. There were supposed to be two of us, but I've been it for since 2012, and really I created the position. I did everything I could to learn the ropes, do what I could to make myself useful. But also because I'm just so curious about things, I said yes to everything. Don't say yes to everything. At some point, you just run out of time to do things. So, a day in the life of Viet looks like now I had to fight for, and I was able to get clinical time back. So I do 2 half-day clinics, one general cardiology, one lipid. In any given day, I'm helping to write protocols for new studies. I'm reviewing inclusion exclusion across 37 trials that I'm involved in. Since 2012, I've written 36 manuscripts, either co-authored or authored, and have been able to present and be co-author or primary author on 97 different abstracts. And what have I leveraged that into? A lot of fun. It's a lot of fun. I would do it again in a heartbeat. I'd be a PA 100 times out of 100 times if you told me to do it again, knowing what I know.
wow, thank you for that. Yeah, I saw on your LinkedIn like all the articles that you wrote. Oh my gosh, like is you for real? Oh my gosh. So I'm sure you've written a lot, like as far as like I mean the JNC8 or the JNC, JNC out of whatever number they're on.
Yeah, well now it's AHA 2017. Yeah, the
Okay.
Joint National Committee no longer is involved. They stopped at 8, JNC 8, and then they moved it over to the American Heart and the American College of Cardiology.
Oh wow, thank you for that.
Yeah.
Awesome. Thank you. So let's see if there's any more. Okay, so great question. So we're gonna end with this. Okay, how much of your days of research how much of your day is research focused versus seeing patients?
Yeah, so great question. And typically what happens is I have scheduled half-day clinic. Like I just finished the end of my clinic today. So 5 o'clock I finished. I still have to do some dictations for the clinic today. But and very rarely do you ever see this happen. But myself and my 3 partners, we give all of our cardiology patients our phone. They can text, call. In fact, I gave to a new consult today. They have my cell, and I tell them, you call me anytime you need. But more importantly, if you text, that gives me an opportunity to respond back. I may not be able to answer the phone every single time you call, so I apologize for that. And what that means is that I see patients all throughout the week if they happen to text or call. And it's very important that they do so because it keeps them from being admitted to the hospital. I can make very small changes to their blood pressure meds, to their lipids, to their heart failure medications without having them wait 3 months to see me again. It's very nice to do it that way. So then interspersed throughout the rest of my week, I'm responding to those types of calls, making notes, and then, seeing patients on both, real patients. I say real patients, but study subject patients are also real. And I do, physical exams. I do inclusion, exclusion for studies, etc., and write, study medications throughout the rest of the week. And a lot of meetings, but I love them because I get to see all my fun, favorite research friends throughout the week.
Wow, that's great. That's amazing how, like, you just, built a life in cardiology and did so much, and all the research you've done and articles. That's great. And that even shows that, all the things that you can do as a PA, especially with research. I had some students ask me about like doing research, and
oh yeah.
Yeah, we had a professor last week come in as well, and you are also a professor. You do it all. Oh my God.
Well, we didn't even talk about my, I teach at Rocky Mountain University, 0.2 hours, and I just cram it in there. Like, hey, whatever.
You teach the cardiology course there, or?
I am the co-course director for cardiology didactics. So, and that's the third semester for our clinical rotations. Throughout the rest of the year, I actually am fairly involved in their standardized patient coursework. I'm a proctor in their standardized patient work. And then, family practice, some of the rotations, I'm sorry, not rotations, but their other semesters have bits and pieces of hyperlipidemia, hypertension, physiology, and stuff like that I will teach throughout the year. But yeah, my winter semester is when I hit the cardiology the hardest with the patient or with the students there at the program.
Okay, I have one last question, and I think a lot of students are wondering this. How do you maintain that work-life balance and, family, having kids, and doing everything, being the Superman that you are? How do you do
that? Well, I don't know if I do it too well. I try. I mean, if you follow me on Twitter, if you follow me on Instagram, you'll notice that I post a lot of fun things that I do with my family because it has to be intentional. So on the weekends, we are intentional about making the time to be together. And my wife has taught me that I need to plan vacation into my schedule. And so I do. She is patient with me and allows me to do everything else throughout my work week. And, we've come to an understanding after 21 years of marriage that it is, it keeps me happy, and happy dad, and kind of like that happy wife, happy life, happy dad makes for a fun time when we're together. And, we go hiking, we go wakeboarding, or whatever. We go on vacation. I'm very intentional about that.
Awesome, amazing. Thank you so much for everything for this session, Viet. We really enjoyed it. I see a lot of students saying that was great, very helpful and clear case study. Thank you. That was so interesting. Amazing. Love that you're sharing this reality as a career changer. Life is a winding road. Thank you so much. A bunch of compliments. Thank you so much. Thoroughly enjoyed this session. Of course, I learned a lot, so I'm sure they learned a lot. So thank you.
Yeah, again, feel free to, connect with me on Twitter if you'd like.
I'm sure they're going to be wanting your, LinkedIn, Twitter, all that information.
So here's my Twitter, and then I am the running bald Asian. Yep, that's my Insta.
Thank you so much, guys. Thank you so much.
All right. Thank you, everyone.
All right. Have a good night. Good night, everyone. Bye.
Bye.